Hello, everyone. Welcome to the webinar. We will start in 2 more minutes, letting some people to join in. Thank you for the patience. Hello, everyone. We will start in 1 minute. Good morning, good afternoon, good evening, everybody. My name is Khan Siddiqui. I'm the Chief Medical Officer and Chief Strategy Officer at Hyperfine. Welcome to our World Stroke Day webinar focused on COVID-19 and stroke. As you know, stroke can happen to anyone at any time, anywhere. It's the number one in 4 adults will have a stroke in their lifetime. And stroke is the leading cause of death and disability worldwide, but almost all stroke can be prevented. So as part of the World Stroke Day event, we have an honor to have a guest, Dr. Kimon Bekelis, give a talk on how has COVID-19 impacted management of stroke and what are the effects around that. Just a little bit brief about Dr. Bekelis. Dr. Bekelis is a neurosurgeon at the Good Samaritan Hospital Medical Center. He's chairman of the Neuro Interventional Services of Catholic Health Service of Long Island and also director of Stroke and Brain Aneurysm Center for Long Island. He's co-director for the neurointensive care there too. Dr. Bekelis, if you can turn your video on and I'll stop sharing so you can start.
Sounds great. Thank you, Khan. All right, thank you for having me. Let me share my screen. Again, thank you for having me. Today's World Stroke Day. So, as far as awareness comes, this is the day to speak about these issues and kind of how advanced imaging, like what's provided by Hyperfine, can really help us, especially in the setting of a pandemic where we have a lot of competing factors, the infection concern, and also the ability to do point of care MRIs right at where the problem is. And as you see, I'm in the hospital and I'm in a comprehensive stroke center. So I was planning on doing this from a better location, but I had to come in for a stroke. So, stroke, as Khan said, happens all the time. There's no easy way around it, and so I'm hoping that I'll have an unobstructed ability to give you this presentation. But if something happens, I might have to move to let the folks here work. So there's been a lot of discussion about the possibility of an association with stroke and COVID-19, there's been a lot of speculation. There's very little data on the matter, but luckily we were very dedicated in looking into if whether there's an association or not. And we recently, I think 3 days ago, published a paper in Stroke, looking at a lot of patients. And I'm going to show you what we found, and I'm going to go through all the discussions and the conversations that have been going on around this disease. These are my disclosures, mostly financial interests that have to do with research studies. And I am a consultant for Hyperfine. I'm not sure why I didn't put it on the disclosure. So obviously take everything I say with a grain of salt. So there's two fundamental questions when it comes to stroke and COVID-19. First one is COVID-19 causing an epidemic of stroke in young adults, and we're past the first wave in the United States. Obviously, in Europe, we're deep into a second wave, and we're seeing lockdown after lockdown in multiple countries. And so there's going to be more data down the line. But really, do we see more strokes in COVID-19 patients that are young adults, which is the premise of a lot of the studies or a lot of the anecdotal evidence that was discussed before. And the second is, can the course of a hospitalized patient with COVID-19 be complicated by a stroke? So how did this conversation start? Well, like everything, it started with a lot of publicity. So there has been a push in national media, especially around March, April, and May, with a lot of neurosurgeons getting out there and talking about a possible association between COVID-19 and stroke. So here's what we would see then on TV. Young, otherwise healthy individuals may experience stroke as early COVID-19 symptom. Research suggests. There was no research really surrounding this. There was just case reports, but folks were quick to publicize and discuss these issues, which is never a good thing when you're lacking data. Same thing. Reputable outlets like the Washington Post would publish things like young and middle-aged people barely sick with COVID-19 are dying from stroke. So we had this idea that CNN here, doctors, coronavirus is causing sudden strokes in some young adults. So there's a few folks out there that were claiming that this is going on, and the majority of us treating stroke and actually the hot zones were having a different impression of what was going on. And we're talking amongst each other. And then we're also, as you know, the US was kind of lagging behind as compared to the pandemic in other areas of the world. And it was weird to us that some physicians would see more strokes supposedly, whereas the rest of the world that has had their first wave already by the time we're having our first wave did not really report much on stroke and COVID-19. So is it just that in the US we're seeing something different, or is it just an issue of perspective? So, you look at the rest of the world, and the rest of the world was talking about this vanishing stroke, disappearing stroke phenomenon during the COVID-19 pandemic era. And this is from Italy, that, as you all know, get really severely hit by COVID-19. Same thing in the United States, in Florida, and China. With the first, I tend to forget where the pandemic started from, and same thing there. It was so severe in the UK that there were public service announcements here through BBC talking about you should not ignore real emergencies during the pandemic. That applies to COVID-19, to strokes and heart attacks. They were calling it the vanishing stroke and heart attack phenomenon, and the World Stroke Campaign also focusing aggressively on stroke and our inability to get these patients to the emergency room. There was this profound fear that if you were to go to an emergency room, whatever symptoms you were experiencing, you will contract COVID-19 and you will be faced with significant problems. Same thing in the US and more, and I mean, not to belabor the point, but you see in Louisiana and Chicago, this is from the University of Washington. So we have some folks, the majority of them, saying, well, we feel that COVID-19 is associated with fewer strokes. We don't see as many strokes. And then I think the most well-publicized approach in national media was, young people are getting strokes and dying from them with minimal or any symptoms from COVID-19. So what's going on really? And it's a matter of perspective, right? If you don't have data, it all comes down to what people think about a situation, a scenario. And I'll show you what our experience was in one hospital, but then I'm going to go broader and look at the real data and try to get an answer about this possible association. So this is 2019 and 2020 from January to April through the midst of the pandemic. How many stroke cases do we see in a comprehensive stroke center in a major metropolitan area? And what we're seeing here is that there is a slight decrease in the number of strokes. And this goes hand in hand with what our impression. Our impression was, gee, strokes are really not coming as, patients are not coming with strokes as frequently. And another question is, how many patients are getting interventions for these strokes? How many patients got interventions in 2019? How many patients got interventions in 2020? We're also seeing a decreased number in stroke interventions. And okay, so this is kind of the year to date, January to April, that date. Is there a temporal pattern? Do we see an association with some change? And how can we correlate that? That's what the temporal pattern looks like, but that I think is more informative. So you have 2020 kind of going up and down, and then you see 2019, and that's the crux of the problem. So you see around March, there's this tremendous dip in 2020 as compared to 2019. And what happened in March? This is where we were in March. This is where we were on our epidemiologic curve, March leading into April. This is the uptick of the pandemic. There's a lot of publicity, a lot of fear out there. People do not want to go to a hospital, especially in New York. I practice in Suffolk County, so we kind of followed Manhattan through Nassau and then came to Suffolk County. And our hospital in particular saw a tremendous number of COVID-19 cases. So this is what you're seeing here. And then you see kind of in April, you see a little bit of an uptick in COVID cases, or in stroke cases rather. And I'll tell you why I think that happened. Kind of you have this initial shock, and then you see a little bit of growth in the number of patients. Now let's look not just at stroke in one hospital, but let's look at stroke in 7 hospitals, the entire health system. And this is based, so this is data that's been published already in stroke. You can look it up on PubMed. And the American Heart Association was tweeting about this today, about our paper, since it's World Stroke Day. And so here's what we're seeing. With the green line, you can see the explosive growth of COVID-19 cases, pretty much mirroring what you would expect in an epidemiologic curve, with an initial kind of geometric growth in the number or logarithmic rather, growth in the number of cases, and then the dip. And then with blue, red, and black, you see MIs, TIAs, and strokes. So you see all these vascular diseases are kind of gently trending down as COVID-19 is going up. So really, now we're looking at 3,000 COVID patients and multiple thousands of admissions in a major health system on Long Island. We're not really seeing that phenomenon. But again, this is not analyzed data. We're just looking at the numbers as they're coming along, and we're trying to identify any correlation. So is there really a correlation? So what you're seeing here is the weekly count of COVID-19. And with you have the less than 60-year-old population with the empty circles, and the dark circles are the ones that are over the age of 60. So we want to see, first of all, is there a correlation between the number of the weekly count of COVID cases and the weekly count of stroke and TIA cases? Is there really a correlation? So if one is going up, is the other one going up? So are we seeing this phenomenon? Are we seeing it on everybody? And maybe we're missing the young, because that's what folks were claiming, that young patients are doing without any or minimal COVID symptoms. They're getting a stroke, and people are dying from strokes related to COVID out there. So you'd expect to see this, right? Or that, if there's a reverse correlation. But what are we really seeing? This is the true correlation. So if you fit a line and you're trying to see here, trying to fit a line to match the data, this is what you're seeing. For the over 60 is the dark line, and the dotted line is for the under 60. So there's really no correlation, or a tad bit negative correlation. And I'm going to go into a regression analysis in a second, but this is kind of striking because it's so dissimilar to what some folks were claiming. And I'll tell you why I think that is. So let's say we adjust for risk factors for stroke. We do a regression analysis, we take age into account, and a multitude of factors. This is not just the ones that I'm going to show you, but I kind of took the regression, it's a forest plot. I took the regression and some of this is just age and female gender, but there is a bunch of other factors: hypertension, hypercholesterolemia, diabetes, smoking, every cardiovascular risk factor, early prior stroke, things like that. What if we adjust for everything and we run a regression analysis? So as you can see, COVID-19 was associated with a significantly lower risk of stroke. Again, very dissimilar to prior data. This is actually, this is the same slide. So really, we're not seeing more strokes in COVID-19 patients. I think that's the most important message, and that's what we published in Stroke. Another question is, do you see COVID-19 patients developing strokes? And the answer, I say, is absolutely. There might be, fewer strokes at the time of COVID-19, but there's still some people who will develop stroke. And obviously, if you're in a high COVID area, you're expected to see some people who will have both. First study that showed something on that was in JAMA Neurology, and it was from the folks at Wuhan, the initial epicenter of the pandemic, where they saw 4 patients with ischemic stroke that kind of concurrent with COVID-19. And this is a small sample. They saw about 2.5% incidence of stroke in these folks. Kind of this is what stroke looks like in their lungs in the setting of COVID-19. So a real question that comes to mind is, what are we, if somebody does have COVID-19 infection with SARS-CoV-2, and in addition to that is having a stroke, will they do better, the same, or different, or worse, as opposed to somebody who just is having a stroke? And I think the evidence is overwhelmingly showing that if you have both, your prognosis is really, really, really bad. So here's another logistic regression. Again, we take into account all the negative prognostic factors for a stroke outcome, and you're seeing that if you're having both, you are 10 times more likely. I think this is on mortality. Yes, so you're 10 times more likely to die as compared to just having a stroke. So really, the combination of both is making the disease very tough to control. So again, we pose 2 fundamental questions at the beginning of this presentation, and here's, I think, the answers. First of all, is there an epidemic of COVID-19 in young adults? I think, although obviously we can never draw definitive conclusions, I think the data is pointing against this observation pretty convincingly. And I showed you a couple of the analysis. Obviously, if anybody's interested in looking at the entirety of the paper, that's available online through PubMed or through the journal, through Stroke. Our paper was the first peer-reviewed paper actually on the matter. Everything else was anecdotal reports. The first one was published. There were maybe 3 patients that had COVID-19 and stroke, and that became, the epicenter of this approach. But frankly, without scientific rigor, we cannot be making these assumptions, and all you're really creating is confusion, and you're creating confusion, and you're creating definitely kind of sensationalism rather than offering the appropriate direction to people. The other question is, can the course of hospitalized patients with COVID-19 be complicated by stroke? The answer is absolutely. There's no question that that's the case. You have a population, for example, New York had 20% of the population ended up being positive for COVID. So if you have such a high prevalence of a disease, there's no question that you will have some folks that will have both pathologies. And if you have both pathologies, it is very clear to me that you're very likely to have a negative outcome. So that's where prevention and early intervention come into play. Now, why did we see this temporal fluctuation in stroke incidence? And this is not data driven. This is assumptions, but I think they're very valid assumptions. And obviously, I would love to hear other people's opinions on this. But it is very clear that folks avoided the emergency room at the peak of the pandemic. They did not want to go to the emergency room. They were having symptoms, and I'm talking about the milder stroke. So if you're having, and I'll tell you something else anecdotal about this, but if you're having numbness, weakness, that's not generalized, you might, in some cases, they might have avoided the emergency room, and then eventually they came to the emergency room the next month to be checked. Primary care doctors were mostly unavailable to evaluate these patients. Offices were closed, so they would end up in the emergency room. At that point, we realized they had a stroke, but really the stroke happened during the peak of the pandemic. Then they came a little later, and so that's why you see that later uptick. The other thing is that during the height of the pandemic, people did not really visit their primary care doctors. They were on Coumadin, if they're on cholesterol medications, high blood pressure medications, generally did not get their maintenance care, and that resulted obviously in uncontrolled high blood pressure, diabetes, possibly not therapeutic Coumadin, and therefore these patients developed clots, developed disease, and ended up with strokes. So if you have a period where you minimize preventative care, and in addition to that, but people don't really go to the emergency room or their primary care doctors, you're bound to have another period of heightened stroke. Regardless, we need to be very careful. And when we're looking at data, sure that there's a temporal association, but really, do we see something that that is justified, or rather where we justify the hype, and that's very that's, I guess, a very important question. And as we said, decrease in stroke during the peak of the pandemic because people didn't go to the hospital, but then increase in stroke at the downtrend of the pandemic because now folks have not been exposed to their maintenance care. Now, the care of stroke patients really changed dramatically at the time of COVID, and that resulted in significant delays. And just as an aside here, if somebody showed up to the emergency room, even the folks that did show up at the time, they did not show up in a timely manner. They did not show up in a timely manner, again, because they were worried. But if you have a very severe deficit, inability to move one side of the body, you will go to the emergency room at some point, even in the middle of the pandemic. But they would come past their 3 to 4.5 hours that we have to give TPA, the clot-busting medicine, and that would really put them in a disadvantage. And so our only option was mechanical thrombectomy, the procedure we do through the groin where we navigate our catheters and wires. We go up into the brain and pull those blood clots out mechanically. And that was our only option. And interestingly, generally, we do fewer thrombectomies as compared to how much clot-busting medicine we give, how much TPA we give, because naturally there's more smaller strokes out there as compared to larger strokes. But really, what happened in this case is that in March, April, and May, we gave very little TPA. I would say in some months, 0. And we did more mechanical thrombectomy. So all these factors kind of came into play. And as you can tell, there's a lot of confounding going on. And we're in the midst of a pandemic at the time. So folks made a lot of assumptions and made a lot of statements. But really, now that we can look at things with a more clear understanding of what's going on, and we have the data and the evidence, we really did not see that impact on stroke care. Now, when it comes, and I'll tell you a little bit about our protocol in the emergency care of these stroke patients, but when you have a patient in the ICU and they have COVID and they're developing a stroke. Now, you know this patient is a very poor prognosis, and maybe I see a question out there, but so they're developing they have a very poor prognosis. The real question is, can you, and these patients, remember, they're very infectious. We do not want to have them go through the hospital, go to other places. They're in special units. There's PPE that's very specific to coronavirus. And so there's a lot of challenges that comes with the care of these patients. And I think that's where Hyperfine really can shine. And we had the machine here at Good Samaritan Hospital before the pandemic. And during the pandemic, it was a good tool to use to get an immediate image of a patient in the room and get an immediate answer. So you don't have to take that patient out of the room. You don't have to contaminate the rest of the hospital. And also the staff that doesn't have to, you do not bring this patient in multiple areas, and you can kind of keep a separation going. And with the pandemic still fluctuating and smoldering around the world and the US, I think this is a key component of the power of the point of care MRI. And I think kind of the FDA approval happened at the tail end of the pandemic, but without a doubt, this is the future of imaging when it comes to point of care imaging. And for us in the neuro ICU, I do a lot of neuro ICU care. Having something like that really can be a game changer, especially since the quality of images we get is extremely well structured to allow us to make decisions that are life or death. Meaning, you're somebody's having a stroke, you want to know if that person, for example, is swelling. Do you need to do something about? Do you need to do surgery? Do you need to do other interventions? You can get definitive guidance from Hyperfine in that direction. And so, get your answer and get definitive treatment without having to move the patient around the hospital, especially in the setting of the pandemic. And I'll show you, for example, another area in the emergency room where we didn't have the ability. And we do have that machine in the emergency room too, by the way. But when it comes to a patient that's having a stroke in the emergency room and we needed to intervene to open the blood vessels in the brain, one of the biggest considerations was how do we deal with a problem that we have an awake patient having a stroke. You need to put a breathing tube down their throat. They will probably aerosolize the virus. Pretty much a significant number of the patients in the emergency room had COVID already. So it's a very stressful situation. So when it comes to the team itself, and I'll answer your question about the increased risk of COVID for the rest of their life. So that stress that came from not knowing the COVID status of this patient, which is true till this day. We do rapid COVID testing, but because when we treat stroke, we treat fast. We don't stop. Patient needs to get their blood vessel opened as quickly as possible. And COVID status is not the first thing we think of. So this protocol that I'm going to tell you has not really changed. At the time. Has not really changed since the time of the pandemic, right? And so what happens is we minimize the amount of people that are in room and outside the room, and we really intubate every single patient that presents with a stroke that needs an intervention. So that intubation happens at this intubation happens in the emergency room. And then that patient gets transferred intubated to minimize aerosolization in the angio suite, because you don't want to expose that patient to the possibility or expose the team to that patient. And so once the patient is intubated, then obviously there's minimal transmission of the virus, and then the team that actually is welcoming the patient and is treating the patient is wearing full PPE with an N95 mask, and that's how we treat everybody, even to this day. In the middle of the procedure, now we have rapid COVID testing. We do it, the patient gets intubated, comes back to the room. In the middle of the procedure, somebody will say they're COVID negative, which is not very common, quite unlike what happened back in the day. And then we continue the care of the patient. But that added time, because now you have to intubate a patient in the emergency room, and the care became a lot more challenging. So these are kind of the modifications that we applied in our practice. But again, COVID-19 and stroke do coexist. I guess that's the message. But in reality, we do not believe that there is an epidemic of stroke secondary to COVID-19, as I think our data has demonstrated very effectively. Now, is COVID-19 a procoagulable syndrome? Most certainly it's a procoagulable syndrome. But we're seeing a lot more venous thrombosis, and actually in the brain we see cerebral venous thrombosis, but we see very, very little stroke in direct association with COVID-19. And I see a question: do you expect a person who recovers from COVID-19 to have an increased risk of stroke for the rest of their life? I don't have evidence about that, but I am, based on what we see and the possible lack of an association, I don't think that's the case. I wouldn't recommend if somebody, for example, has had COVID-19 to be on an aspirin for the rest of their lives. I really don't. I would not change my cardiovascular risk profile assessment and treatment based on whether they've been exposed to COVID-19 or not. I would consider a patient, based on their cardiovascular risk factors. I think we very effectively demonstrated in our study that there is no such association between the two. Again, thank you. I think it's a great opportunity to raise awareness for stroke on this day. We're very passionate about it, and we're very happy to be collaborating with Hyperfine and the whole team there to improve the outcomes of these patients.
Thank you, Kimon. That's great. There's so much confusion and so much information that is all over the place, and seeing some evidence-based data really helps us. One quick question. Again, one of the things comes up in the media all the time is loss of smell and loss of taste, and it stays longer. Any comments and thoughts on that?
Absolutely. So, this is a virus that obviously starts the mucosa, and our olfactory apparatus is at the top of the nose. So this virus seems to be affecting the olfactory apparatus to a large extent. Now, that not everybody will have loss of taste or smell, but a lot of people, they seem to have that issue. Now, that is obviously an insult of the olfactory apparatus and either the mucosa or maybe the nerve endings. But in reality, that doesn't really correlate with stroke per se, or a generalized neural insult. Like any virus, you can have neural presentations, or like any virus, like influenza, you can get into a sepsis scenario or a septic shock where the patient is really, really sick. And when you are in these scenarios, you'll see more clot forming. You'll see more peripheral thrombosis across the body, splenic artery thrombosis and kidney strokes, infarcts rather, and other issues, and DVT, and you name it. And we frequently even thrombosis in the pulmonary blood vessels themselves, and there's been trends in putting patients on heparin if they're going to get intubated to minimize or to improve oxygenation from preventing these clots from forming. Now, these small vessel clots are very unlike large vessel occlusion in the brain. So the pathophysiology of the two is very different, and I don't think the two should be confused. I think it's very clear that one and the other are not related. But as I said, every virus can cause an insult to nerves. It can cause encephalitis, inflammation of the brain, and obviously systemic inflammation from a generalized infection, especially somebody who's extremely sick from this virus, can cause a lot of presentations. Now, the fact that there's no epidemiologic correlation to the population, that doesn't mean that if you have a COVID patient, as we said, you're not going to see a stroke. You'll see strokes. In some studies, about 2% you'll see strokes. And know that if you do see, mortality is a lot higher.
Just a reminder for all attendees, you can ask more questions with the Q&A session. You can tab at the bottom of your screen. Another question that I get all the time is, there have been some reports on imaging findings related to cytokine storm, and the pathophysiology behind that, and what do you actually see? Any comments on that, thoughts on that? Again, it's only the few reports. So have you experienced something like that?
You said the pathophysiology of what?
Cytokine storm findings in COVID patients, so neurological high intensity signals seen sometime in
yes,
and things like that.
Yeah, I don't think we know. Obviously we see it, right? And I think it's been studied, and Hyperfine has played a role in identifying these, especially in very sick patients. But I don't think we know. Obviously, if you did cadaver studies and you had autopsy reports, you'd be able to make an assumption of what that really is. But I think trying to speculate on what's going on, it probably ties into cerebral insults similar to systemic disease and similar to a cerebritis or inflammation of the brain. I don't think that this virus is particular neurotropic. I don't think it targets the brain preferentially than any other organ. A lot of people believe that there is an endothelial insult, meaning the lining of the blood vessels is insulted or affected by this virus. And by that, endothelial insult, endothelium exists throughout our body, and it exists in the brain, and it exists everywhere else. And so if there's endothelial insult, you expect to see these changes. No question, you expect to see these changes in the brain.
A multi-system disease, right? So, and some people show up with cardiac issues, some people show up with neurological issues. It's really, really complex thing to think about. Just talk about, like, I mean, I know we're talking about stroke management here, but the whole workflow aspect. You touched a little bit on the ER scenarios, but how has the impacted the imaging aspect of the workflow, right? When you need portable X-ray or X-ray needed or CT needed and MR needed, especially in neuro ICU settings and post-procedure type of scenarios, like how you change your workflow around it.
It's very challenging. There's no question about it. The biggest challenge is obviously the fear that's inherent to a disease that's potentially life-threatening, that's airborne, or rather droplet transmitted. I don't know that that's been resolved yet, so I shouldn't say something like that. But in any event, it's challenging, and there's logistics that come from utilizing a space that then needs to be used by another patient, and that is, say, a biplane room or a CAT scanner or whatever have you. And so once you utilize these spaces, now back then, it was the Wild West. Obviously, we're in the middle of a kind of a disaster scenario, but right now we've come up with protocols. We know how quickly the air circulates. If you do a COVID patient, for example, in a room, you might not be able to get anybody in the room to clean it for, say, 20 minutes or for an hour in some other rooms with poorer circulation, because you need to get all the air out and then get the patients, get the folks in, because you really want to make sure that you're protecting these people. Now, in an emergency room setting, right, where you have a CAT scan machine, and that needs to be used fast, because, you have a COVID patient in there followed by a brain trauma. Brain trauma cannot wait 20 minutes, cannot wait an hour, cannot wait a second. They need to get in there right away. Or stroke, or what have you. I think that's where Hyperfine really excels, because you have a portable machine which you can sterilize in between patients, bring it to the bedside, do the scan, move on to the next patient, sterilize the machine, move on to the next patient. Whereas when you're utilizing a space, and that comes, same thing for the neuro ICU, obviously. You do your scan, you move the machine. The machine is easily sterilizable. It's not a big deal. It's all plastic for the most part, and metal. So it's not something that requires time or requires any particular treatment. And I think that's the key to the future of imaging when it comes to something like a pandemic or an infectious disease problem. I mean, Hyperfine has a lot of benefits that come from the ability to get images at the point of care without having to move unstable patients, but we're adding to that a very, very stressful scenario. And our imaging protocols have been affected, obviously. Emergent imaging used to be a horror show. You couldn't really figure out the logistics. Now, if you're electively treating a COVID patient, it has to be at the end of the day. You have to be able to the ability to shut down that space for a certain amount of time. It's still extremely inconvenient.
Yeah, so these changes that, I mean, I keep hearing from my colleagues in radiology is that, the portable nature of all radiology has, really taken off, like, clinicians expecting, portable X-ray machines in clinic scenarios, so they don't want to send the patient down to radiology, so they want to do imaging over there. So a lot of these practice patterns are changing, more acceptance on doing things and detecting things on point of care ultrasound, portable X-rays, portable CT, portable MR. What do you think? This trend is here to stay, or is going to go back to where it was? Like, any thoughts, predictions here?
Did you say about coronavirus?
No, I'm just portable. The workflow changes to becoming more.
I think the changes are here to stay, because obviously they came in a forced way through the pandemic, and a lot of things came in a forced way, including what we're doing right now, a Zoom meeting. But there's some benefits to this, and also the tail end. So, even if there's a vaccine and the pandemic is generally under control, I do not expect a zero number of cases at some point. So this is going to linger for a while, and we all need to be vigilant, and we all need to stay on top of the problem. And I think these protocols, if obviously we have the protocols in place, we're not missing much we're actually adding to our ability to safely treat patients. And you don't want to be in a similar scenario as we were in March, April, and May. And so I think people are going to be very hesitant to go back into the old ways.
There's a question about, can we see more stroke images from Hyperfine and how much time was needed to capture them? Can you talk about the time side of things, and then go ahead.
Yeah, so I don't think we can see more stroke, but I think we can see the same amount of stroke using Hyperfine. I don't think we're going to miss any strokes in a diffusion image. The time needed is the same as an MRI to capture these strokes, and I think there's useful information that comes from an MRI machine. Obviously, you know, a lot of us are used to CT, ACT perfusion. MRIs, if you can get them, it's fantastic. You just have to correlate a diffusion weighted image with a flare image to make sure that, for example, if they're both kind of matching, that area of the brain is dead, so there's not a lot of help that you can offer that patient. But if there is a mismatch, that's what we call penumbra in the MRI world, similar to the CT world, and that's a patient that you can intervene on and help them.
Yeah, absolutely. And the person who asked this question, if you wanted to see more images, there's some on the website, but please reach out to us. We can set up a call in time and walk you through some of the cases that our various sites are collecting and doing it. So it's pretty impressive to see how this is happening. One question for me, right? I mean, all of these scenarios, when these things happen, you know, you always go back and reflect and do a retrospect and see, like, you know, what would you have done differently, right? So if you had to now, in your hindsight, what you did in stroke management in these patients in the early days, and what you would have approached differently now that you know about this and gone through this one scenario once, and God forbid happens again, what would you do differently?
And, you know, hopefully it's not going to happen, but you know, if history teaches us anything, is that it repeats itself. And you know, we're seeing Europe being under a lot of stress currently, and it's likely to, you know, mortality to kind of start creeping up also in the U.S., and the health system to start getting a little bit overwhelmed. You know, we did learn a lot from the pandemic, and when things started, we were definitely you know, deer in headlights when it came to stroke care. I think what we've done now, and that's what we've learned, obviously, be very aggressive. If you don't know somebody's COVID status, treat them as positive. You know, test everybody that walks through the hospital door, because the hospital is a very high risk area. Obviously, people are sick, and COVID patients are sick, so they'll be in the hospital, in and or around. Staff can have COVID, so, you know, be very careful about addressing the community acquired component and also the hospital acquired component. But really, when it comes to the emergency care, treat everybody as COVID positive, take all the precautions, and N95 is a very important component when it comes to that. You know, I mean, I'm not wearing one, but it's right next to me because when I'm done with this, I'm going to put it on and go about my business. But it's very important, especially when you're treating patients with unknown COVID status. You have to take all the precautions, you know, N95, face shield, all the stuff that we do, and try to minimize, you know, maybe at the beginning and at the very early on, people were a little willy-nilly with the aerosolizing procedures. A lot of clinicians got COVID. You know, maximum really PPE and precaution, even PAPRs need to be worn for intubations. And if you're intubating somebody, do it in a space that's not going to need to be cleaned. You know, for example, if you're doing a procedure, try to intubate the patient outside of the procedure room. Once you bring the patient inside the procedure room and you put a breathing tube in, all your materials, everything is contaminated in that room. And so keep the patient kind of separately from that. So intubate the patient in the emergency room, bring the patient to your procedure. And so these are all the things that we've learned in the protocol that I showed you, is kind of how things were shaped after the initial confusion, deer in a headlight kind of scenario where it was a free for all. You know, there was limited amount of PPE, and there was limited amount of a lot of things. But I think we're a lot more prepared now, at least in terms of understanding the disease to some extent, understanding its impact on the brain, and understanding how we can make a difference for it.
That's awesome. So I think we have a few seconds left in this. What I'll do is just anybody who really wants to learn more about it, get a demo from us, see more images, please go to hyperfine.io website, click on contact, and reach out to us. You can fill out the form and we can reach out to, or you can call us directly also. More than happy to set up a separate time to do demos, as well as show more cases if folks are interested in it. Dr. Bekelis, this has been amazing. A lot of great insights, cutting through all the noise that happens in the media and actually looking at some scientific data and what is happening. And
Thank you.
we
Thank
are,
you. Our pleasure. And thank you for having me.
I mean, I think it's, we're the right solution at the right time that came out, and we are almost deploying and the scanners on a daily basis nowadays. So it has been tremendous, and it has caused stress on us to move fast and get things out.
In the middle of a pandemic. So, kudos to you guys for being able to scale. And you're doing a tremendous job across the United States and major academic centers, getting the word out there. It couldn't have been a better time for Hyperfine. Obviously, a lot of stress for everybody else, but we're very happy with the collaboration. And thank you for spreading stroke awareness. Obviously, thank you.
Thank you very much, and thank you, folks, and everybody have a great World Stroke Day. Please get the awareness out. Get more people aware of it so that we can recognize symptoms and get them treated properly. It's a very debilitating injury. So, thank you. Bye.
Thank you. Take care. Bye-bye.